Good evening and welcome to Advances in Treating Achilles Tendon Conditions with the HSS Education Institute. As Claudia said, I'm Brian Goonan, your host for the evening. I am also the recipient of an Achilles tendon repair at HSS. So I have a vested interest in sharing the information I've gleaned over the years. We have two informative presentations followed by a Q&A session tonight with Dr. Richard Asla and Dr. Gregory Rubin. Dr. Richard J. Asla is a board-certified, fellowship-trained orthopedic surgeon specializing in foot and ankle disorders at HSS at NCH in Naples, Florida. Dr. Gregory Rubin is a primary sports medicine physician at HSS at NCH, specializing in ultrasound-guided injections, acute injuries, fractures, arthritis, chronic overuse injuries. We're excited to have both of you here tonight. First, we'll start with Dr. Rubin, who will discuss non-operative treatment approaches. Dr. Rubin, over to you.
All right, thank you very much. I'm gonna get my slides here. All right, so good evening, everyone. So I'm gonna start out with showing, basically we're gonna do a little overview of some anatomy, the typical presentation, and then I'll go into some treatment algorithms from the non-surgical side. And then we'll give it over to Dr. Diaz to go into some of the surgical options and also focus more on the rupture side. So, we can't start to talk about the Achilles tendon unless we know what the Achilles tendon is. So, of course, anatomy-wise, if you look at the screen on the picture on the left, you're going to see, two heads of a muscle on the left and right, known as the gastrocnemius muscle, and they basically will come together as well with the soleus muscle, a deeper muscle, and those two muscles will come together to what we are better known as the Achilles tendon, which attaches down in our heel. Now, I put this picture up because I'll allude to some of the things, in a couple of slides, but what I wanted to highlight were two structures in red, which will be important for some of our pathology. We can have what's called a subcutaneous bursa, which is going to be something that we'll see in a later slide that can get distended, as well as a retrocalcaneal bursa. So it's not just going to be about the tendon, it's going to be about some of those soft tissue structures as well. This second picture, last little bit of anatomy, I wanted to just highlight a little bit about blood flow because so much of our Achilles tendon pathologies and treatment algorithms will be dependent on this image showing the blood flow. Two arteries will kind of give us our blood supply to the Achilles. And there's this area highlighted in this picture in blue there that's a zone of hypovascularity, fancy term for not a lot of blood supply. A lot of bad stuff can happen here. This could be an area where we have ruptures, where we're prone to tendonitis, and we'll go through maybe some, in a few slides, what the treatment options will be for those locations. All right. So I wanted to show first, and how I frame tendinopathy and how we think about it. The image on the left is going to show you organized bundles of what we call tendon fibers, right? So you can see they're nicely organized, homogeneously arranged. The image on the right is now showing you what a disorganized tendon looks like. This term tendinopathy that we're using, which is this disequilibrium, disorganization of the tendons, which our body then will try to heal with, these disruptive blood vessels, new nerve growth, and basically scar tissue. So, I highlight this because a lot of the pathology we'll see in the Achilles tendon, it's hard to make a tendon on the right act like a tendon on the left. And that's where some of our challenges will come from. Just basically the same image in a different view. On the right, you'll see that white structure. Now imagine that white structure is your Achilles tendon, meaning muscle becomes tendon, tendon grabs onto bone. As we just mentioned, you can see the disorganized fibers on the left. It's highlighted the same way on this image of a tendon, and this disorganization of sometimes we, are either prone to developing Achilles tendonitis symptoms, tendinopathy, even, as far as tears go, a little different, but I wanted to highlight from the tendinopathy standpoint. So who gets it? That's always the number one question we get. It's common. It's very common, especially in Naples, where we, like to think of ourselves as the pickleball capital. So, in a regular clinic, every, more than I'd say we see a much higher rate, but 2 out of 1,000 patients in the community, and ruptures and up to 10 per 100,000. Found most commonly in our active adults, 30s, 55s, obviously, we're much more active, even up to the, mid 80s and 90s in April. So we'll see Achilles pathology running the whole spectrum. The picture below, we don't have to spend too much time on. It's trying to just, again, highlight that when we're saying this term tendinopathy, we're trying to highlight this disorganized fibers. So, as I kind of alluded to that, it's pickleball injury. Well, a lot of our patients are active in pickleball or golf and tennis, and they're going to give us a vague complaint. Hey, it hurts behind my ankle. It sometimes hurts when we start activity. It sometimes hurts, just over time or, by the end of the activity. So the history doesn't clue me in from when it hurts and when it doesn't hurt. But really, for us, it's a lot of it is, where do you hurt? Have you noticed swelling in this area? Have you felt a pop? What have you tried for it so far? Is pickleball a new sport for you? Have you never played before? Are we just aggravating something maybe that was pre-existing? Before we jump into, some of the treatment, I wanted to also just show there's the Achilles tendon is a little bit different than other tendons. It's not wrapped in nice, smooth synovial fluid to allow it to glide. It's wrapped in what's called a peritendon. It's basically an outer wrapping that allows the Achilles to glide in. So just wanted to highlight that before we get into some of the diagnosis and treatment, because that structure allows the tendon to glide is important in our pathology. So your clinical exam, when you see a provider for this, going to be pretty straightforward. We're going to, obviously take a look at it first. We're looking for thickening of the tendon either in the middle or pain and swelling down where it meets the bone at the bottom of the heel. We'll use multiple treatment modalities for diagnosis. Sometimes it involves a standard x-ray to see if there's any calcifications in the area, and I'll show you a picture of what that looks like. I'll use an ultrasound to assess the fibers in the office to kind of see if they're disorganized or if there's scar tissue formation. And then even MRIs for either to confirm, ruptures or tendon partial tears or tendinopathy. The hard part is always to tease out what's real and what's not real. We'll find in, almost 35% of patients some asymptomatic Achilles, that have pathology. So I'm sure, some of our listeners have had this or, noticed it on someone before. It gets a name of a pump bump or a Haglund deformity. It basically, and I spoke about it in the beginning, that subcutaneous bursa, that fluid sac right behind the Achilles, you can see it on the image on the right, can become distended, as well as the tendon in that area can have swelling. And it's going to be one of our signals to think of what we call as the insertional variety of Achilles tendonitis. So that's one of our symptoms or signs that we're looking for. When I mentioned, hey, on an x-ray, what do you see? This picture is looking at someone's heel. So that big bone on the bottom is the calcaneus. And you can see on the far left some little calcium fragments. And those are going to also be sources of posterior heel pain and can be aggravating to the Achilles tendon and cause swelling in the area behind the heel as well. And then finally, from a picture standpoint of the imaging, I highlight in the image on the left what an MRI image will look like. It's that thickened black Achilles tendon in that watershed region where we see scar tissue that can collect. So that's going to be, the imaging side. Now, just to further highlight the two varieties before we go into treatment, there's the non-insertional. So insertional meaning down at the bottom of the heel. The non-insertional is that thickened mid portion of the Achilles you can see on the right. And how we approach treatment, typically first line is physical therapy. And there's going to be some different modalities that we talk about as far as, when we write a script to our physical therapist of what things that we'd like to see them do. Before they get there, a lot of the patients will say, well, what am I going to do today? How can I leave here when I'm in so much pain? And what this picture shows us is we'll sometimes place patients with a little bit of a heel lift. Now, it's important to note that heel lifts are not meant to be a forever thing. We quickly tell our patients, over the first week, we decrease that stack by one, and then another week by another. So we're not meant to stay in an Achilles lift forever because it can, shorten the Achilles and have some adverse effects. But it is an easy tool to use for acute pain if someone's seen in the office. I wanted to show this picture because it's a technique that I'm sure Brian's very good at. It's Graston technique. It's a scraping technique. It's what we use as really the main tenet of our therapy for Achilles tendinopathy, because what this is doing, and think of it like a butter knife kind of scraping up and down that tendon, is it's helping break down scar tissue. It's helping encouraging blood supply, which again, we said the biggest issue is scar tissue and disorganized fibers. So we need blood and we need to help work out scar tissue. We'll also do strengthening, of course. Anyone who's done physical therapy knows there's a strengthening component. We use something called e-strengthening, eccentric strengthening, which is if you look at the weight, it's not the up, it's the slow down to neutral, trying to stimulate, formation of the good type of collagen. As I alluded to in the previous slides, the peritendon can get very inflamed as well. So some of our treatment options from, outside of physical therapy could involve injections into the area around the tendon as well. We are very careful. We usually do not put corticosteroids anywhere near the Achilles tendon as it could increase the risk of rupture. But what makes the Achilles unique, that outer sheath, is sometimes a candidate for platelet-rich plasma injections. And we have a little information on what PRP is as well. So PRP is where we take your blood. That little picture on the right shows you what happens when we spin your blood around and we separate it out into different components. When we take that and use an ultrasound and guide it into the area around the Achilles, what we're hoping happens, as you can see in this picture, is all those little colors are different actions that different components of the PRP can help attract your body's nutrients to. So, there's different types of growth factor that can help with, new tendon differentiation, help foster this environment for good, healthy tendon, formation and growth. So, just to briefly, and I know I went fast to summarize, two different types of Achilles tendonitis, the non-insertional and the insertional varieties, as well as inflammation around the outer sheath, both amenable to physical therapy. There are alternatives with injections such as platelet-rich plasma. We really try to shy away from the corticosteroid variety. And that's it. That's our non-operative side.
Thank you very much, Dr. Rubin. Takeaway is pretty much that the challenge with Achilles tendon repair is that the normal healing that happens with adequate blood supply, we don't really get in this unique structure of the Achilles tendon, and physical therapy could potentially help with some reintroduction of some fresh blood supply, some fresh oxygenation and muscle building cells. And if that doesn't work, there are also some other options to do. Did I summarize that correctly?
Beautiful. Yes.
Okay.
Easier said than
Perfect.
done, though, right?
Always. Yeah. And I've been doing Graston for a long time. We actually have now started using BFR as well. We are not allowed to do dry needling in New York State, but definitely in the surrounding states, that's a big modality as well. But ultimately, it just comes down to strengthening. Like if we could get it stronger, it's going to become more resilient to just the in and out of daily activity and maybe the higher level activity as well.
Yep. Time is important.
For sure. How much time would you expect it to take non-operatively from initial onset to return to a pickleball event? How much time would someone give it?
So we usually recommend not even, following up in clinic for 8 weeks of physical therapy, and it could take longer. It could be 8 to 12 weeks. It really, tendons are slow. And that's what I try to stress to our patients is be patient. It's going to be a long process.
Right. And when would you put the brakes on and say, okay, I don't think this is working anymore? When do you?
Oh yeah. So at that
When
good
do
old 8 week follow-up, that's when I send you down the hallway to Dr. Diaz.
Gotcha. All right. So I assume down the hallway at NCH is where Dr. Diazla practices. And if Dr. Diazla, if you're ready for your surgical approaches, we're ready to hear from you.
These are my disclosures. First of all, my name is Rich Diazla. I'm an orthopedic surgeon, as you heard, and I specialize in foot and ankle orthopedics. That's really all I do. I'm an employee of NCH, but I'm also a consultant for Arthrex, so that is my disclosure. We will be talking about some products that pertain to that company, but I get no royalties. And so you've heard all this before now, but repetition is the key to learning. And so again, the back of the heel, I don't know if you can see the cursor. Does the cursor show up on the?
Yes, we
it
can
does.
see it.
Perfect. So again, quick review of the anatomy. The Achilles tendon, largest and strongest tendon in the body. It inserts on the back of the heel bone or the calcaneus. And wedged between the tendon and the back of the bone is this thin sac of fluid, or it should be thin, called the retrocalcaneal bursa. And bursas are just these structures that separate tendon from bone. They can separate skin from bone. They're these anatomical barriers. And as Dr. Rubin mentioned before, this could be part of the pathology and pain. And of course, we have the bump in the back of the heel, the so-called Haglund's deformity, which is a misnomer. It is not a deformity. Everybody's got one, but it may be part of some of the pathology for folks who have heel pain. You've seen a slide like this before. The Achilles tendon blood supply is a bit wispy in the center of the tendon, which is probably why most of the ruptures occur there. And quick definitions: tendonitis, inflammation, and tendinosis, degeneration. So two very different concepts that Dr. Rubin discussed, and we'll be hearing more of those terms throughout the talk. And again, we have two flavors of Achilles tendinosis. We have the insertional type that occurs where the tendon inserts on the back of the heel. And then we have the non-insertional type where degeneration occurs largely in the center of the tendon. Interestingly enough, it is rare to see both at the same time. You tend to either have one or the other. Now, you can certainly have a tendinosis that involves the entire tendon. That's very uncommon. Now, not all Achilles tendon pain is from a tendinosis or a tendonitis, and so it is our job to sort through that. Some folks can have inflammatory conditions. There are medications such as fluoroquinolones, which is ciprofloxacin or Levaquin. These are fluoroquinolones that are known to cause Achilles tendinosis in about 2% of folks who take those medications. But typically, if that's to occur, it occurs within days of taking the medication. It usually involves both Achilles tendons, and it usually involves the entirety of the tendon. So for the most part, we don't have much difficulty making the diagnosis of Achilles tendinosis. It's a generally straightforward diagnosis to make because patients' symptoms are so similar. And you've seen this in a previous slide: thickened Achilles right in the middle. That's the non-insertional variety. And this is what you will typically see in that insertional variety. Oops. And part of that swelling is probably, in this particular case, due to a swollen bursa. Again, a bursitis in the back of the heel that often is associated with the pathology. So from this point on, we're going to assume that the patient has failed all of Dr. Rubin's conservative measures. And they are at a point where they feel that symptoms have not improved enough to their satisfaction. And they come down the hallway. Now, oftentimes they come to me with a diagnosis already made. Sometimes they come to me as a first opinion. So we always get x-rays in the office. But as I mentioned, we don't need imaging really, for the most part, to make the diagnosis. Every so often there'll be that curveball. We're not sure what's going on, but the vast majority of these patients come in with very similar complaints. We'll get more advanced imaging, though, all the time, such as MRI, for preoperative planning. And the reason that's important is because there are some general tenets that we stick to when we're going to operate on somebody with Achilles tendinosis, whether it's the insertional or the non-insertional variety. And what you're looking at here is an MRI, and you're looking at the side view. We call that the sagittal view. So this is the heel bone or the calcaneus, and here's the Achilles tendon as it comes down and inserts on the very back of the heel. And it's subtle, but you'll see this little white streak in there, and that's where the tendon is degenerative. Now, in this particular case, this is not a very bad looking tendon, but there's a big bursitis there. So in this particular case, the strategy is you will debride that small debris, meaning remove the diseased tissue, and remove that prominence in the back of the heel. And the MRI gives me this roadmap because when I'm in the operating room, I actually don't see the tendon as well as I do on the MRI, which is why we always get MRIs when we take people to the operating room. And here's a case of a non-insertional Achilles tendinosis. So Dr. Rubin showed a slide very similar to this. You have this widening of the tendon. The normal caliber of the tendon should be this, but this is several times thicker than that. And we call this fusiform enlargement, this kind of fusiform shape like a Tylenol. And you'll see in the center of this, the tissue gives a bit of a bright signal as opposed to this very dark signal. And this is the degenerative collagen that Dr. Rubin was alluding to. And this is a pain generator. And so if this person comes to surgery, we need to remove that. And MRIs give me an understanding of what the extent is. Sometimes these are associated with tears. So we always get MRIs before surgery. Now, most of the time, fortunately for folks, non-operative treatment is very successful, at least 75%. It's probably much higher than that. It turns out that if you have the non-insertional variety of Achilles tendinosis, those folks tend to do better with the non-operative modalities. The folks who have the insertional variety, they're a little tougher to treat non-operatively. That's not to say they can't be treated. Again, most of those do well too, but the non-operative, the non-insertional variety just seems to respond better to our non-operative modalities. Now, effectiveness is related to a few things. The duration of your symptoms. The longer you have symptoms, the tougher it is to get over it. The severity of the disease, obviously, if there's more diseased tendon or a much larger spur in the back of the heel, it's tougher to get over that with non-operative measures. And unfortunately, this is an age-related condition, which is hard to swallow as I get older, but it's true. You don't see this in 20-year-olds. Rarely do you see it in 30-year-olds. It's folks in their 50s and above that we're generally seeing the condition in. And so when do you, quote unquote, need surgery? No one needs surgery for this because no one ever dies of Achilles tendinosis. This is purely a quality of life decision. The patient has to decide whether or not they have enough symptoms to warrant undergoing what surgery entails. And are you willing to make the lifestyle changes necessary to reduce the symptoms? For some folks, pickleball, basketball, tennis, that's their life, and they're not willing to give that up, and they want it fixed. And that's very much a personal decision. That is not a decision that the surgeon makes. You can make this decision with the surgeon, but you don't let the surgeon make that decision. This is not a life or death thing. So the premise in treating both varieties of Achilles tendinosis is, number one, you have to excise the diseased tendon because it's a pain generator. And then you have to decide what you're going to do with that tendon after you've removed the tissue. And in the case of non-insertional Achilles tendinosis, we don't have to worry about bone. So here is an exposed Achilles tendon, and it's this white glistening material right here in the center. It can be difficult to tell the difference between the diseased tendon and the healthy tendon, which is why MRIs are so valuable. Now, in certain cases, enough of the tendon is degenerative, greater than 50% is generally our cutoff, whereby you can't simply repair the tendon and hope it doesn't fail by rupturing. And there was a study done in Australia looking at that. So if more than half the tendon has to be removed in order to get rid of the diseased tissue, you've got to augment it somehow. And there are various techniques, and I don't mean to get anybody nauseated, but I thought I'd show some films. And we have a variety of techniques to help us reconstruct a tendon that is very degenerative and is not primarily repairable. In the worst cases, you actually have to remove a segment of the tendon. You remove a segment of the tendon, but of course you can't leave it that way. Otherwise, the calf muscle is not attached to anything. So we have to reconstruct it with graft. Nowadays, we tend to use allograft, which is cadaver tissue, essentially, that we get from a tissue bank, so that we don't have to steal tendons from the patient, robbing Peter to pay Paul. We can use these allograft tendons, and it's amazing what the body can do around these tendons as a scaffolding, reconstructing its own Achilles tendon around the graft. For those who have the insertional variety, the principles really are the same. You have this diseased tendon. The difference is where that diseased tendon is. It's attaching to the bone. So you have the bone component that you have to deal with in addition to the tendon. So like the non-insertional variety, you remove the diseased portion of the tendon, but you also have to remove the spur that's back there. And so here's an incision in the back of the heel. So this is the very bottom and back of the heel. This is the Achilles split in half. It's very, very thickened. The thickened tissue is excised, giving access to the back of the heel bone. And we remove that Haglund's bump. We remove the spur that's back there. But again, if you have to remove over half the tendon, you worry that that's going to rupture later on. And so even in these scenarios, if you have to remove a very sizable portion of the tendon, you have to reconstruct it. And there are techniques for that. So in most cases, the tendon, the native tendon is left in place. You remove the back of that spur and the Haglund's deformity in the back of the heel, and you excise that diseased tendon, and the tendon gets repaired back to the bone, and we have anchor systems that allow us to do that. And here's an example of a Haglund's resection, or that's our fancy doctor word for removing the prominent bone. And that's what it looks like when it's done. And that allows for space between the tendon that would be back here and the bone. And so now the bursa has a nice big space to live. It's not being sandwiched between the bone and the tendon. But again, in certain circumstances, if you actually have to remove the Achilles tendon, you need to do something to subtend the gap that's created. And this is an example of a tendon transfer where we steal a tendon from the big toe, and it makes up the difference as you attach the Achilles tendon to the tendon up here, and this makes up the rest of the tendon, and that will mature with time. You can also use allograft for this as well. And so the post-operative phase of this is really quite lengthy. The surgeries are all outpatient, and most of the surgeries are 35, 40 minutes. They're not very long, but we really do set you up for a bit of a recovery because, as Dr. Rubin alluded to before, tendons just don't heal quickly. So we will tend to keep people off of the foot for about 2 to 4 weeks before you're in a walking boot. And when you're in a walking boot, there's heel wedges that go in there to take tension off the tendon and slowly remove those wedges, allowing the heel to get closer and closer to neutral. And physical therapy is a critical component of all of these cases. Now, most patients have already been to physical therapy by definition, but they've got to go back and kind of start all over again. And the recovery is really upwards of 4 months. And many folks will tell you that it gets better over the course of an entire year. The good news here is at the end of the road, for most patients, the success rate it's better than 80%. And so that's the positive news, but it is a bit of a slog to get there. So let's switch gears. We live in pickleball land, and of course that sport has now become infamous for Achilles tendon ruptures. I came from Boston, and most of the Achilles tendon ruptures I saw were basketball, but that's not the case here in Naples. So the overall incidence is about 8 in 100,000, and most of them are sports related. Males outnumber females at least 2 to 1, and some studies as high as 12 to 1. So this is mostly males, but females can rupture their Achilles tendons too. And the sweet spot for this, if you're really looking at, if you had to pick the median individual who gets an Achilles tendon rupture, it's that white collar worker who intermittently participates in sports. They're kind of your weekend warriors in that 30 to 39-year-old range. However, what's interesting is the distribution of Achilles tendon ruptures is really bimodal, meaning that's your biggest cohort. However, once you get into your late 50s, early 60s, the graph rises again. So there in your 20s, you're relatively protected. You get to your 30s and the rates go up. And then as you get into your late 40s and 50s, the rates go down. As you get your late 50s, early 60s, the rate goes up again. So this is a bimodal distribution. And here in Naples, we see that second bump. So pathomechanics, that's our fancy doctor phrase for how does this happen? So why are certain sports prone to this injury? What is it about pickleball? What is it about tennis? What is it about basketball? Because we don't often see Achilles tendon ruptures in runners. So what ends up happening is in those sports, when the athletes find themselves in positions where their foot is planted against the ground, their calf muscle is contracting, but the foot is going up or dorsiflexion at the same time. We call that an eccentric loading. So the muscle is trying to push the foot down, but the activity is forcing the foot up while the muscle is contracting. So this puts huge forces across the Achilles tendon, and racket sports do this most often. So when you're chasing a ball, running towards the net, and you stop to hit it, you're leaning forward, your foot's on the ground, you're trying to push off to prevent yourself from going forward any further, but the foot is still going in an upward direction. In basketball, when somebody's about to drive the lane, they get low and they sprint forward, the foot is going up for push off, but because they're bending their knees, the foot is actually going up as the gastrocs and soleus and the calf contract, and that is a very common mechanism. Not, you can see Achilles ruptures, of course, in soccer and football, but those sports are particularly menacing to the Achilles tendon. And pickleball is a sport that's become so popular for older folks, often who haven't really stretched or been conditioned to play, and they get on a court, and it's not unusual for us to hear about an Achilles tendon on people's first day of pickleball, which is an interesting conversation because oftentimes they come in with a spouse who is enticing them to play pickleball, and then they rupture their Achilles tendon on the very first practice. And that's always an interesting office visit. And so when somebody ruptures their Achilles tendon, they often have the same complaint. They get a sense that somebody kicked them or threw a rock at them, and they turn around and nobody was there. And that's what it feels like. And often it's an audible pop. Others can hear it. And interestingly enough, most people who have an Achilles rupture don't have any preceding pain. It just ruptures. Now, there is a subset of folks who have Achilles tendinosis as well, and they can rupture their tendon, and they may have had some pain, but the average individual gets no warning for this. It just simply happens. It's amazing how many of these go misdiagnosed, and largely, I think the reason is because you would expect that an Achilles tendon rupture would be very, very painful. Now, it's startling at the time, but ironically, after about 24 hours or so, it doesn't hurt very much. And folks can walk on it. Now, they have difficulty with push-off. They have a lot of difficulty with stairs. But we have patients come in having been referred to physical therapy, and it's the physical therapist that discovers they ruptured their Achilles tendon, and the patient thought they had a sprain. So on the exam, it's generally not challenging to make the diagnosis. Now, we will get imaging studies many times, but you often don't need an imaging study to make the diagnosis. There'll be swelling around the injury site, and it'll be black and blue. Our term for that is ecchymosis. But there's often a palpable gap in the tendon. You can run your finger over the tendon, and it just falls right in, and it's a very palpable thing. There's a test we use called the Thompson test, whereby we squeeze the heel, and in an average individual, when you squeeze the heel, the foot should naturally jump. That test is positive, meaning when you squeeze the heel, the foot doesn't move. And if you have the patient lie prone on the examining table and you compare it to the other extremity, most of us have a certain resting position of our foot, and the rupture side looks like this. It's lagging. So it's really not a difficult diagnosis to make. Now, having said that, it's medicine and nothing is perfect, and sometimes you get confused. We're not really sure what's going on. Is it a complete rupture? Is it not? Do you need surgery? Is it? And you'll get MRIs to try to sort those things out. But more often than not, it's a fairly straightforward physical exam. Now, back to the anatomy, most cases of Achilles ruptures occur in the middle of the tendon. And remember, that's where that watershed area of blood supply is. Now, having said that, not all of them are there. Some of them occur much higher, and some of them occur right at the insertion. And all of these come with nuances when it comes to repairing them. We'll go over that in a little bit. Again, only about 10% of folks who rupture their Achilles tendon had any preceding discomfort in their Achilles. So in the past, the conversation with patients who had an Achilles tendon rupture was a pretty straightforward one. You had younger active patients, you fixed them. You had older patients who weren't necessarily active. Maybe they had comorbidities such as diabetes or heart conditions, and you didn't fix them. And it was a pretty quick conversation. But the conversation now has become more nuanced. And the reason is because non-operative treatment for Achilles tendon ruptures has proven to be hugely effective. And there are a number of meta-analyses demonstrating that. And since we've moved to Naples, and we do have an older population playing pickleball, they're very active, we had been more inclined not to operate on them for other medical reasons. And we were following the protocols set forth by some of my colleagues for non-operative care. And I am amazed at how they do. And we'll go over some of that. In some countries, because of these functional rehab protocols for non-operative management for Achilles ruptures, the surgical management has decreased by more than half. And so this is very much worth talking about. So I think in most people's minds, an Achilles tendon rupture equals surgery, but that is not necessarily the case. And so It's also important to realize that non-operative treatment does not mean no treatment. You're being treated in a very organized way through protocols. It's just not operative treatment. But early detection of the injury is key if you're going to have a good outcome with non-operative treatment. We'll explain that in a little bit. So there's a meta-analysis for anybody who really wants to do a deep dive on this. Back in 2012, there are others now as well, looking at 10 randomized controlled studies. These are high-powered studies comparing operative versus non-operative management. Now, in the past, papers have been very strongly suggesting that if you have your Achilles tendon repaired, the risk of re-rupture later on is much less. And if you don't have it repaired, the risk of re-rupture is higher. And that may or may not be true, but these meta-analyses are challenging that mantra. And this particular meta-analysis saw no difference in the rate of re-rupture between operative and non-operative care. Surgical group, understandably, has a higher complication rate, right? There's no wound in non-operative management. And so we have to take that into account when you're doing any kind of surgery. There's going to be a risk of complications no matter who you are. That's just inherent to the field. The surgical group did get back to work a bit sooner, but there was no difference in the calf size, strength, or functional outcomes as they measured it, which is a very big surprise when you consider how we historically looked at this condition. Now, having said that, others have done research on athletes, looking at how they do a year and a half later. Now, this is published in the American Journal of Sports Medicine, again, a randomized controlled trial. And they found that folks who were treated surgically had better calf strength and better physical function as determined by the RAND 36 Health Survey. So, okay, so some evidence to suggest maybe later on you're a bit stronger. Here's another randomized control study looking at significant improved hopping and counter movement jumps. And counter movement jumps are jumps whereby an athlete squats down in a really low position and jumps as high as they can. So there is some evidence to suggest that on very rigorous functional scores, patients who have surgery may do better in the long run. That is challenged by some of these meta-analysis, but nevertheless, there's literature out there. And having said all this, you'll probably never find a professional athlete or a high-level college athlete who ever treats these things non-operatively. They all get them fixed. Now, that may be because of some of these studies. It may be because that's how historically we've been doing it, or it may be because no one wants to take a chance of taking a risk on a high-level athlete with a non-operative management, and if they don't get back to their sport. And it is worth mentioning that even with operative management, about a third of folks just don't get back. I mean, it's a very difficult injury to overcome. And everybody who ruptures their Achilles tendon misses the season. The season is over when you rupture your Achilles tendon. You're now playing and training for next year. So what is functional rehab? This is the protocol we use for those non-operative management, but ironically, it's really very much the same as our operative management. So usually we have people off it for about 2 to 4 weeks. For folks who have not had it repaired, we have to be particularly cautious because there's no sutures in there, so there's less strength, so we're a little slower. But really the protocol is very much the same. At about 4 weeks, you're weight bearing in a boot with wedges. The wedges are slowly coming out over the course of the next 4 weeks. At about 8 weeks, you're out of the boot, you're in a functional brace. All these modalities and measures are to prevent the foot from going up too high and stretching in the repair. And the repair can stretch even beyond 4 months. This is why we're so protective of the tendon. And if the tendon stretches, that manifests itself as weakness later on. So we want the tendon to be the length it was before it ruptured. That's really the goal of surgery. That's the goal of non-operative treatment as well. But we try very hard to prevent the tendon from lengthening because, again, that will manifest itself as weakness. So we mentioned high-impact athletes, they get it fixed, okay? In the old days, we used to have to make these giant incisions. Nowadays, we use percutaneous approaches, much smaller incisions, some very clever techniques. In fact, one of the foot and ankle surgeons at Special Surgery was highly instrumental in some of these techniques that we're using now. The smaller wounds, early return to sports, fewer wound issues. And here's an example of how it works. basically an incision is made right over where the rupture is rather than making an incision the entire length of the tendon. This device, it's called a suture passer or a pars suture passer, is inserted. So those little inside prongs are surround and capture the tendon, and the sutures are passed back and forth in a predetermined pattern through the skin. And then that device is dragged out of the wound, pulling the sutures behind. There's a locking suture technique that we won't go over here that locks the suture to the tendon, and then that process is repeated for the other side of the tendon towards the heel. And then both sides are then tied together through the wound, and you wind up with a wound that looks like this or oriented longitudinally. Different surgeons have different preferences, but these are very small wounds. And this has really reduced the post-surgical risks. And the biggest risk after a surgery like this would normally have been wound complications, but that risk has been markedly reduced with these newer techniques. There are challenges to the Achilles tendon rupture that comes off the back of the heel because there is no tendon to repair it to. The other problem is because there's no tendon left if it avulses off the back of the heel, even the body's unique ability to heal many things is thwarted oftentimes, making it difficult even for the body to heal it without help. We are far more likely to want to repair these surgically than let these go and see if non-operative treatment is successful. Now, fortunately, this represents probably less than 15% of all ruptures, so we don't see very many of these. That's the good news. The bad news is should it occur, you're probably winding up with a construct that's going to look like this. The other area the Achilles can rupture is right after it changes from muscle to tendon. We call that the musculotendinous juncture. And the challenge there is that there isn't tendon above the rupture, it's muscle. So that percutaneous technique I showed you, when you pass the suture through the muscle, it wants to kind of pull through. And so we often try to repair it that way, but we prepare the patients and let them know they might wind up with a much bigger incision than we had hoped, because sometimes we have to go back to the old technique to repair these proximal ruptures because we need a good grip on the muscle, and those percutaneous techniques are not quite as good as the old techniques for grabbing tissue. And so that's what I've got, okay? And hopefully we didn't go too long. And I'm ready for questions.
Thank you, Dr. Asla. It looks like a lot of the surgical techniques have to be individualized to the client. And it's good to know that there's a lot of different options out there, and that non-operative care is still somewhat effective. I myself, as a non-high level athlete, I would have never thought that I would not go with the surgical route 7 years ago when I tore it playing beer league softball.
Right.
But it was just one of those things where, like, sometimes and I probably because of my profession, I'm just like, I just want to get this repaired. It just takes the shadow of doubt out of it. But yeah, so we have 4 questions in the chat. 2 are related to extracorporeal shockwave therapy. Have either of you had any experience with it? When is it appropriate? And what's its effectiveness level?
Yeah, so we don't currently offer it at our clinic, but there are studies showing some evidence for tendonitis or tendinopathy. It's not going to regrow fibers, but using those similar principles of, putting in this shock wave, meaning applying this shock or vibration through the tendon, again, to help stimulate tenocytes or help stimulate blood vessel formation to help with healing. There is emerging evidence. It's just typically not covered by insurances, so we found it, has been a little difficult to get started with.
Yeah, so shockwave is real. It's well studied. There are prospective randomized studies on shockwave. I think it was FDA approved in this country in 2004. It's been being used in Europe well before that. There are 2 varieties: high energy, low energy. The high energy machine has demonstrated better efficacy, but it's also painful, so it may require a bit of anesthesia. It's expensive. The machine itself is expensive. There's a transducer there that has to be replaced every time it's used, and insurances don't cover it. So that's often cost prohibitive. I think one of the knocks on shockwave is there seems to be a recurrence rate that happens after about a year. So it may not be not that patients can't get relief, but that relief may not be durable. Having said that, it's very safe. I mean, there's other than some local tenderness after the procedure, there's very little downside to it, quite frankly. And so if the price tag doesn't chase you away, it's not an unreasonable thing to do. I think it's fair to say, though, we always start with physical therapy because the success rate there is so reasonably high. Why not start with that? And we're going to modalities like that when that modality has failed them. And they're very much looking to stay out of an operating room, and I don't blame them. They should be. But I think the preference is PRP first. It's often a proven modality, less expensive. But there's nothing wrong with shockwave. There's data out there that people could read about. It's worth mentioning, and Dr. Rubin mentioned before, do not let anybody inject your Achilles tendon with steroid. That is a never event, never. Nothing good is going to come of that. If you have Achilles tendinosis, by definition, you have a degenerating tendon that is trying to heal itself. And when you introduce steroid into the mix, it stops the ability of the body to heal itself. That's what steroid does. It's like injecting 1,000 aspirins. It cannot continue with the healing process, which is why the rupture rates after steroid injections are so high. So just don't let anybody do that to you.
Okay, we have a couple more questions that are coming in wildfire. So if you guys want to, I'll kind of summarize them together. And if you want to give them like a thumbs up if we approve or a thumbs down, that's okay too. Does PT help repair damage resulting from taking Cipro?
So that's a good question. I'll give it a thumbs middle. Usually the cure is stopping the offending drug. Thank goodness. So in the vast majority of cases, most folks do well just stopping the medication. I think, and this is anecdotal, I don't have a study on this, but we send folks to physical therapy anyway for it. And I think really what happens is they get better faster. They're probably going to get better anyway, but they get better faster. So we still send folks to PT for the condition. That's a good question, though.
Okay, another question is, what is the difference between tendinopathy, tendinitis, and tendinosis? And is there a different treatment for each one?
Yeah, I'm gonna jump in on that. So think about the tendinitis portion for the Achilles as inflammation around that outer sheath called that, or not sheath, but that peritendon. That's the tendinitis inflammatory side. Tendinosis and tendinopathy, both broad terms for this disorganization of the tendon fibers. So kind of one and the same there. The treatment options for, sorry.
Yeah, so it's unfortunate because the language in medicine can be confusing. Often the terms are more confusing than the concepts. And so tendinopathy and tendinosis, really tendinopathy refers to any kind of condition of the Achilles tendon, whether it's a tear, a rupture, or tendinosis. Tendinosis very specifically means degenerative changes of the tendon. A tendinitis is a misnomer because it's not the tendon that's inflamed. In the case of the Achilles, it's the perotenon, that sheath that surrounds the tendon that's actually inflamed. Nevertheless, we use the term tendinitis. That's a very different entity than a tendinosis.
Okay, we have two questions on gastrocnemius recession surgery. Is it effective? What is it used for?
So that's a more recent concept. And so the concept behind a recession, so let's take a step back to the anatomy. So the Achilles tendon is the product of two tendons. It's the product of the gastroc muscle and the soleus muscle. One muscle sits on top of the other in your calf. And those fibers come together and they twist about 90 degrees to make the tendon, and the twisting effect is like a rope. It just gives it strength. In cases of usually insertional Achilles tendinosis, one of the theories is that folks may get Achilles tendinosis if they have a gastroc contraction. So when they go to walk and they go to push off, the Achilles is constantly pulling on the heel, and in time that creates this degenerative process or tendon breakdown. And by doing a gastroc recession, you're isolating the gastroc component of the Achilles before it becomes the Achilles tendon, and you're literally releasing it. So theoretically, that allows the foot to come up higher because now the gastroc isn't a restraint anymore. And then eventually it scars in. And there are studies on that. The problem with it, though, is that when you do that, almost inevitably, you're going to get atrophy of the calf because the gastroc is no longer pulling like it used to, and the muscle is going to atrophy some. So that's a potential consequence. So now some of my colleagues champion it, and others don't do that as a modality for Achilles tendinosis. My approach is I tend to use the more traditional approach. If you have insertional Achilles tendinosis, debride the tendon, remove the large spur that's often associated with it and the Haglund's deformity. If that fails and you have a reasonably healthy tendon, in other words, you're not worried that the tendon is a pain generator, then you can consider a gastroc recession going forward. The recovery from that is far less onerous than the Haglund's resection and Achilles reattachment. I hope that answers the question.
Okay, and we'll go through a couple of different modalities that people are talking about now. Does a week of oral steroids help with the recovery?
No.
There's no evidence to support that.
Yeah,
I mean, we could sometimes use it off-label for the inflammatory peritonitis, but yeah.
It's
All right, how about
it's for pain relief. It doesn't solve the problem.
right? And how about collagen supplementation and Voltaren?
I'll sometimes recommend the topical Voltaren for the subcutaneous bursa since it's pretty superficial. As far as collagen, will it grow new tendon? Probably not. Is there things to be learned about it? I'll say yes, but we don't know yet.
Are you talking about, is it collagen supplementation, oral supplementation, like glucosamine conjoined sulfate? Because I'm unaware of any study to suggest that, because if that's the case, there's no evidence of that. There was a push for that stuff a long time ago for arthritis. When I was back at Mass General in Boston, a colleague of mine had a very funny comment. He said it's, taking collagen supplements for tendonitis or for arthritis is like telling a bald person to eat hair. It just doesn't work that way. Okay. You eat collagen, therefore it's going to pop out somewhere, and it just doesn't work that way. And
right.
So, once those substances were studied in double-blinded studies, one published in the New England Journal of Medicine, you notice that it all largely went away because it was no better than placebo.
And then I'm going to summarize a couple of the questions that are all together about if you're not getting better with traditional care, what is your next step?
Define traditional care, meaning
conservative care. If you're going to PT, if you've tried some of the Voltaren treatments, KT tape, if you're doing all of the things that people said they should be doing, when do you call it like, okay, I got to figure out a different treatment option, and where would they seek out a new treatment option?
Well, that's what we talked about that before. So, once you get through Greg's clinic and you have failed non-operative measures, conservative measures, and that could be physical therapy, PRP, maybe shockwave, activity modifications, and failure is defined by the patient, not by the physician. I mean, the patient is the one walking in their own shoes or living their own lives, and they have to decide whether or not whatever level of discomfort they have is acceptable or not. And if they decide that their level of discomfort is not acceptable, and they don't want to live this way, and they're not willing to make the changes required to reduce symptoms, and sometimes that means just walking, which is obviously not realistic. And so there's your answer, and then it becomes a surgical solution.
Okay, and that's probably all the time we have tonight. Thank you, Dr. Rubin. Thank you, Dr. Asla, for your time, and hopefully we can speak sometime in the future.
Thank you.
Okay, enjoy your evening. Take care.
Bye.